So we're just waiting on Jim to come over from the other room right now. See everybody's moving into the room. Glad you're all here. I hope you all enjoyed Dr. Cole's presentation on remote patient monitoring. There was a lot to be learned. Hello, Munrith. How are you, my friend? Good to see you. Glad you're here. Glad you're all here. So without you, we wouldn't have an event. So, all right. So, Rob, let's see. Let's find out where Jim is right now. I will call him, although he should be here already. Said he was all keyed up and ready to go. Oh, he's still in the other conference.
You ready to go?
Yeah, let's go. Come on over, brother.
Okay.
All right.
Here, I'm just sitting here.
All right. You got to open up.
Waiting for indication.
See in our session here? You got to be in your session.
Yes.
You got to leave there and come into the other room, into your room. Remember?
I thought you just automatically do
No,
this.
you did this already. You got to come in our room.
All right, I'm coming into my room.
Come in your room, my friend. Your
This
room.
is preview.
There you go. Preview join.
Here we go. I'm ready.
All right. See. That's how this technology works. He preview join. There he is.
The only thing we didn't practice was transferring from one speaker to me. That was good. No, I was waiting for a ping.
I knew you were waiting for something. I had to call you.
I know. I got the ping.
All right. So next up is Dr. Jim McGuire. Dr. McGuire is associate professor at Temple University and
full professor now.
Excuse me, sorry.
I've moved ahead. I moved up. I got to do this.
Full professor. And there must have been people in the other room. Everyone has to come over to this room. So
okay, that might be.
All right. So you can key up your presentation and we will rock and roll.
Just got to find out. Share screen. Where's my screen?
Lower left, share screen.
There it is. Share. And then I'll do this.
Yep. There we go. All right, take it away, my friend.
All right, you ready?
Yeah, let's rock.
All right, hi, gang. Today we're going to talk about this ABCESS system that we developed, and it's kind of interesting. I think that it's an interesting way of thinking about wounds, and it'll help you kind of organize your thoughts as you kind of progress through this. These are my disclosures. I have research grants now from Osiris and Redress. Osiris is coming to a close. Promotional speakers for Smith Nephew Osiris, Embed 3M, and Pure and Clean. And I'm a consultant for NewS and Embed. So we developed this ABCESS, and if I can show you later, but it came out in a special publication by Wounds a little while ago last year. And it was a way to organize my students' thinking for both teaching about wound care, but also to organize an approach to a wound care patient so that you could think your way through this. And another way of looking at it is with this little grid that you have, which is for A is for all medical conditions and wound bed, biopsy and bioload, biofilm, circulation, exudate, skin offloading and protection, and then the social, societal, spiritual, all the, sometimes what we could consider the touchy-feely parts of wound care, which often are the main thing you have to deal with when you're dealing with patients and compliance and adherence. So rather than go through everything on here, we'll just keep moving. So we're going to look at all the underlying medical conditions. When a patient comes into you, sometimes your immediate response is to walk into the room, glance at their face, and then rivet yourself on the wound on their foot and not take time to really do a thorough history and get to know them a little better. And this involves really learning about all the patient's diseases, all the things that led up to the development of the wound, everything that's involved in their previous care for this, and previous cares that other people have rendered, and kind of the results of those. There's a lot of things to consider. Many comorbid disease states, and we're going to see a slide in a second that kind of pulls this all together. Paying attention to nutrition and hydration, and just because they're overweight and ruddy looking doesn't mean that they're eating well. What kind of medications are they on? Do they have any presence of infection or any other infections in their body? They have problems with incontinence, particularly with people that have come in with wet dressings and wet shoes, etc. And then what's their mobility level? And are they walking, or are they non-walking? Are they in a dependent position all day? Or are they like with their foot on the bed all day? So Carolyn Fife published this little paper, and she had a blog on what she called "Wounds with No Name." And it's very interesting that these 5 conditions that when a patient, you look at the medical registry, there's 5 conditions when a patient has any 3 of these things, Medicare is guaranteed to spend over $60,000 a year taking care of that patient: stroke, kidney disease, heart failure, asthma, COPD, or depression. And then if you add those together, you have 3 of those together, you're dealing with a pretty sick patient. And many of our patients with wounds have really significant medical problems. And they're never just one. Like this nonsense about trying to classify a wound as arterial. Rarely is a patient arterial. There are diabetics who smoke, who occasionally drink too much, and have kidney disease and have arterial disease. So the predominant feature that you're looking at may be arterial, but there may be tons of overlay with many other conditions. And when you're looking at these things with all these other conditions on here, and you look at a patient like this, and you're trying to design a study to have the perfect diabetic foot ulcer with nothing else wrong with them, if you have any of these things in here, you're going to get honest healing rates less than 50%. Laboratory workups should be and could be extensive for these patients, so you have to make sure you either get the information as a podiatrist from the patient's primary, or you do these studies to look at. Ones on the left are sort of the standards that we do, and then there's others on the right that you can order specifically for a specific type of wound that's coming in, or a specific patient that you want to evaluate further. Imaging studies, you always want to get any of our patients that come in with a hole in their foot, they always get an x-ray. Because even if they don't have any depth to the wound, it's nice to have a comparison film on file that you can look at for just subtle changes in bone cortical irregularity that may point to the development of an osteomyelitis in the future. And then there's either specialty scanning such as MRI, vascular ultrasonography, CTs, and particularly those SPECT CTs, which just give you a gorgeous picture of the limb and what's going on. Do a good nutritional assessment. Take the time to find out what they're eating. If you can, there's this mini nutritional assessment that's available. It's Nestle puts it out. You can download it. And you want to pick up on things that are in their life, in their diet, in their habits that are putting them in a position where they can't heal well. One study showed that protein deficiencies is present in almost 25%, a quarter of the patients that are hospitalized. One, that tells you how sick they are. And then 2, their access to good nutrition is often very low. The B part of the mnemonic is to next start thinking about looking at the wound. And you're going to look at the wound bed. You're going to try and make a decision on whether you think there's a biofilm present, whether or not you're going to have to deal with that in some way. How old is the wound? Is the wound older than 2 or 3 months? Has it been around a while? Are you considering a biopsy? Because it just doesn't seem to look right to you. And generally, a good guide to go by is if the little bird in your head says, that doesn't look right, just biopsy it. There's no harm in biopsying a wound. And the amount of information that you're going to get from it is just terrific. So you're going to take and do all these things. You're going to make decisions about what dressings you're going to use. We're going to talk about that in a second under drainage. And then whether or not, if this is an older wound, say, 4 weeks plus, whether you're going to use an advanced product such as a cellular or acellular tissue-based product. And now there's these new, scientifically created artificial skin substitutes, which are coming out of the market, which complicate or expand the market even more. We developed this poster that we put up, but it's really based around this protocol that you see over in the box on the left-hand side, for sort of improving wound hygiene. And that's part of the wound bed management. One of the things we try to do with every patient is get a good history, observe and measure, assess the biofilm risk, get a culture before you do anything to like work on the wound hygiene or wound bed, and debride the wound. Check out everything to do with the peri-wound and everything. Cleanse that. We always cleanse everybody with hypochlorous. We switch from saline to hypochlorous. I do speak for a hypochlorous company a lot because I totally believe in it as a cleanser and an addition to your practice. Makes a huge difference. Debride all the non-viable tissue from the wound, and then we soak it again. And we happen to use hypochlorous in this particular evaluation, we have noticed a significant reduction in infections showing up on our wound. And just a quick thing about this: if a wound never gets infected, we will rarely ever see osteomyelitis. You will rarely see an infection-related amputation if the wound never gets infected. And how do you do that? You keep it clean from the front end up. Can we order cleansers for patients that are covered by insurance? No, they always have to purchase them, or they're going to get a free one from the system, which is usually saline, which has no antimicrobial, effect at all. So then we're going to apply a hydrogel or whatever we choose to use. In your practice, you can use silver, you can use hypochlorous, you can use polyhexamethylene biguanide. There are a number of them out there. Choose your dressing, offload as appropriate. Look at your home care instructions and make sure you have specific nursing and home care instructions for the family to use. That's the protocol we use. And then how do we relay information back and forth to each other? You're going to use a classification system. The nice thing about the abscess mnemonic is no matter what happens in the next 20 years, it'll fit in a mnemonic. So if we change our classification to something else, you'll be able to put it in here and put it right into your protocol and use the same mnemonic to migrate your way through. The other reason abscess was developed was time and dime, which is great for wound bed, wasn't inclusive enough. It didn't spread out and cover enough of what you have to look at in a wound care patient to aid the person in staying on track with making sure you always do the right thing. So wound classifications give everybody a common language. So if everybody knows the classification and applies it correctly, you know exactly what you're dealing with when you see the wound. Classifications are divided into a number of ways. The easiest and most accurate is classification by depth. Partial thickness, full thickness. Most people get that right. The NPUAP is probably one of the more complicated staging systems, and that's for pressure ulcers only. You don't use this pressure injuries. You don't use the NPUAP staging system for any other wound. And when they ask you what stage a wound is, they're really asking you what's the depth and the involvement of a wound. Wagner has its own problems, which we'll talk about in a minute, but that's the one that most people use for hyperbaric oxygen chambers, and many clinics use it as a general ulcer grading system. Wi-Fi we'll talk about specifically when we get to circulation. University of San Antonio, Texas, diabetic foot classification. Diabetic foot only, no other ulcer type. SEEP is for venous ulcer, but not for ulcer classification. It's really interesting. It's venous disease classification leading up to an ulcer, but then the ulcer is usually classified based on Wagner in most clinics. And then burns, which are a very specialty clinic. Simple one is depth, partial versus full. Most people get that right. The nice thing about that is partial thickness wounds heal by regeneration with little or no scar tissue formation. Full thickness wounds heal by scar formation, granulation, contraction, epithelialization. Takes a long time, and you don't get a real dermis regeneration. The NPUAP system, which is to look at pressure injuries or pressure ulcers, is definitions of localized damage to the skin or underlying soft tissue, usually over bony prominence related to a medical or related to a device, can be open skin or intact skin, may or may not be painful. It's really something that may be affected by a lot of things. It's usually pressure or pressure and shear, and there are a number of things that contribute to the development of the problem. Just go on the NPUAP site, and you'll get this nice chart that you can use. You can either use the European one or the national one, and I like the NPUAP, which we just stay with all the time. And it goes from suspected tissue injury to a stage 1 which is red, non-blanchable, intact skin, usually over bony prominent, evaluating blanching, and dark skinned people may be difficult. So if you swing back and forth between skin types, you'll get really good at looking for problems in dark skin. But if you see mostly a white population for a while, and then you have to evaluate the presence of slight changes in skin color and tone, you often rely on your fingers, and you want to be careful to make sure that you're not missing something. Partial thickness 1, stage 2, or loss of dermis, or a blister that you can see the bottom in. If you can't see the bottom of a blister, it's non-stageable. So a blister with blood in it, it's non-stageable. A blister with fluid in it is stage 2. Stage 3 goes all the way down to subcutaneous tissue. Fat may be visible. You may see slough, undermining, but it doesn't obscure the depth of tissue loss. The monoslough in there doesn't allow you to not know how deep the wound is. Full thickness tissue loss, which is stage 4, and you may get down into parts. I call it parts. Students go, how do you know the difference? It's like, can you see something that looks like some kind of part, even if you can't identify it? If it's a tendon or a tendon sheath or muscle, then you know you're down stage 4. Unstageable wounds are full thickness where the ulcer bed's covered by either slough or a black eschar. If you can't see the bottom, don't stage it because you may not really understand the depth of loss. Deep tissue pressure injury, DTPI, is this non-blanchable, deep red. Skin's not broken, but you're really foolish to classify this as like a stage 1 by mistake, because what happens is on the record, your care of the wound went from a stage 1 to a full thickness ulcer, and as this tissue breaks down and opens up, and all this necrosis like breaks down and liquefies, you're going to end up with a deep wound, and it's going to look like you treated it and made it worse, but it really didn't. And from the very beginning, it was full thickness injury all the way down to the bone underneath, and it just takes time for that to evolve. Do not use these to describe vascular, traumatic, neuropathic, or dermatologic conditions. Just an ulcer, pressure ulcer, that you can't determine where it goes or how deep it is. This is my problem with Wagner. It works easily for me, but some people only use full thickness ulcers with osteomyelitis in the grade 3 category. You get into hyperbarics where it needs to be a Wagner 3 to qualify for many of the hyperbaric treatments, and they quickly classify it with the Wagner scale using the idea that grade 3 represents any infected wound. So you have 6 grades of severities: a pre-ulcer, superficial, penetration through sub-Q, down to bone. And this is where it's confusing, that stage 3 is, I use that as any infected wound, whether it's full thickness or partial thickness. If there's a cellulitis and an infection involved, I'll use a stage 3. And it's really supposed to be designed for deeper wounds that are infected. But even a shallow wound that's significantly infected has a significant risk associated with it. Gangrene's easy. It's gangrene part of foot and gangrene whole foot. And most of the time we're dealing with a toe, toes, or a forefoot or a lateral aspect of the foot. And a grade 4 is more common than a grade 5. University of Texas, you have 4 grades of depth. 0 is a pre-ulcer, full thickness, tendons, capsular bone, and then and grade 3 is bone. Stages of comorbidity, just think of A-OK, bugs for B infected, C is cardio or cardiac or circulatory, and then D is double. So if you have circulatory problems or vascular problems and an infection, you have a D wound. As you progress through this, from the upper left-hand corner, an A0 down to a D3, your risk of amputation and complication significantly improves. Pre-ulcers are calluses that have a little hemorrhage in them. And often these are not adequately debrided. You take a little of the callus off and you see that and you just say, oh, that's just a little hemorrhage in there. But if you examine these further, sometimes this is not the same foot, obviously, but you'll find under the ulcer, you find this serous fluid or hemorrhagic fluid that is dissected between the dermis and the epidermis. And if it's happening under callus, you often can't see it. Do this comprehensive wound assessment on any wound. use the word assessment, which really helps you think about it. But these are all the things that you need to try to put in the record regarding a wound. The anatomic location and age, that's A. Size, shape, and stage. Presence of sinus tracts. How much exudate. If sepsis is present, systemic or local. Surrounding skin, peri-wound integrity, what's it look like? Maceration, edges and epithelialization potential or actuality, necrotic tissue present in the wound, and then the bed itself or tissue bed, describe the types of tissue. That's only in that order. I wouldn't progress through it that way, but that helps you remember each of the component parts that you need to have. Try to measure. You can either measure anatomically. You can see on this wound you have, longest length and widest, or longest width, longest length, and it's anatomical. But often I think you're more accurate measuring the longest length, and then 90 degrees to that, the widest width you can find to actually measure out the extent of a wound. That's up to you. Either way is acceptable, and there's no one that says you have to do it one way or another. This may help you. We developed this Temple University SLUF classification. It's going to come out in a publication pretty soon. It's taking a little while, but we use it all the time to have the student describe to me, well, what's the wound bed? What do you mean SLUF? It's one of those words that we use it all the time and nobody likes it because it doesn't tell you anything. So we use 4 different types. Fiber slough is predominantly tough fibrous tissue. You usually have to get a curette out or a scalpel to get it off, and you have to kind of whack at it to remove it from the wound. Leucoslough is soft. It's predominantly loose accumulation of white blood cells and a buildup of some fibrin on the wound surface. It's easily removed, often with gauze, and sometimes with just very light curettage. Necroslough is necrotic tissue that has become macerated. So you have an eschar, you debride it, it starts draining. The escherotic tissue that's left is this kind of tough, it's often fascial tissue, sometimes muscles, subcutaneous tissue. And it's not just a fibro base, it's actually necrotic material that you're trying to remove from the wound, and that would be considered necroslough. And then bioslough is when you have a predominantly biofilms, the right side, where this section of the wound and most of this wound has a biofilm on the surface. So we would call it a wound with necroslough. Circulatory things. I think the main thing here is you do arterial, venous, and lymphatic, and don't leave out lymphatic. Arterial ulcers, punched out, painful, usually fairly well delineated. Know your risk factors. And again, a lot of our patients come in with hypertension, diabetes, a history of smoking, hyperlipidemia. This is a little hard to measure right off the bat, but they're like an old guy with renal insufficiency. And then different races have different risks. And you just have to put all that together to try to figure out what you're dealing with a patient. And then most of these are arterial risk for peripheral arterial disease, but then there's venous and lymphatic risk too. This is the Wi-Fi system. Know this. This is a great system for classifying wounds. You look at tissue loss, and the W is for wound, and it has a similar depth to many of the classifications we've seen so far. No ulcer, shallow ulcer, deep ulcer, extensive deep ulcer, or an ulcer on the heel, which is always fairly common. Ischemia. Whether you go from a 0, 1, 2, 3, I just want to make sure that we are still sharing. You guys still see that? Rich, you still see that?
No, you lost your screen.
Or did the sharing come off?
Did you turn off the
screen?
Did you stop sharing your screen?
Yeah. No, I might have hit the button. There we go.
Very good.
We're back. Okay. So ischemia, they use a mixture of some of the different ischemic classifications, and it's the ABI is 0.8 or greater, 0.6 to 0.8, 0.4 to 0.59, etc. And you're looking at the different levels of ischemia. That stop sharing button at the bottom wants to be touched. That was my problem. And then the infection is classified by IDSA or PETUS, which would be no symptoms, local infection, sub-Q, mild infection, local infection, but greater than 2 centimeters erythema, still no systemic response. And then 3 is local infection with signs of SIRS or a systemic infection. And that's 2 or more of increased temperature, increased heart rate, respirations, and an elevated white blood cell count. And that's a severe infection. If you put them into a grid and you look at the wound depth, you look at the levels of ischemia, and then you look at the presence of infection in those wounds, and you can see this is an estimate of risk of amputation at the top, and anything in the red zone has a high risk of amputation, and then likelihood of benefiting from revascularization for that wound, and that anything in red again is likely not to be not to be helped very much by revascularization procedures. Always do non-invasive studies on these people. At least get, in addition to pulses, get your PVRs and look what the waveforms are coming into your wound and whether this wound has the potential to heal. And sometimes get advanced studies. We usually refer most people to a lab for a full study to be done. And then immediately, if we find any abnormalities, they're hooked up with a vascular surgeon for immediate consideration, especially if they have any kind of gangrene or anything. But at least quickly that they be seen when they have a wound. Venous ulcers, classic presentation, lots of skin discoloration, inverted wine bottle look to it. But not all swellings is equal. But in my opinion, all swelling is lymphatic. It has to do with an overwhelming of the lymphatic system, and compression is the cornerstone of therapy. So any of these diagnoses on the left can be a source of inflammation and fluid overload that may lead to swelling, and there's a lot of them. You have to know the difference between lipedema, lymphedema, and venous insufficiency. And it seems like, this is easy compared to something like that. But then you get into these wounds that are what are called phlebolymphedema. And I think most of the wounds that we see that have a lymphodematous component are actually phlebolymphedema. They have chronic venous insufficiency. They get high filtration pressures. They get a watery edema, low protein edema that exceeds the lymphatic transport. That creates an inflammatory condition that leads to fibrosclerosis, a high protein edema, damages the lymphatics, and then you get a secondary lymphedema that's developed. It kind of looks like this progression, eventually looks like that, and it is predominantly lymphatic overload. So the most common cause of lower extremity edema in the United States is phlebolymphedema. Venous disease, the SEEP classification goes from no visible signs or anything to reticular veins, or those little spider veins we don't like, varicose veins. Then you begin to see some edema develop, secondary lymphatic swelling, pigmentation or eczema from stasis, lipidermatosclerosis or atrophy blanche, and then fibrosis and necrosis, and the edema persists. 5 is a healed venous ulcer, and the only reason that in there is it's almost as dangerous as a venous ulcer in the classification system, but it's not quite the same as having an active open ulcer. Once you have an ulcer, you're always a 6. There's all these types of compression that you consider, and you want to pick the one that handles the problem, that is easily utilized by the patient or by the home care agency you're working with, and that's going to give you something that's long lasting. So most of the time they start with something that might be a non or short stretch or long stretch dressings, multi-layer compression dressings. They then move on to something like that's either a circate or something they can apply easily, or stockings and garments for long-term management, and then the use of intermittent segmental compression devices. What you don't want is this, that they're just home wrapping their ankle with an ACE bandage, inappropriately applied with lots of high pressure, low pressure areas that can result in increased ulcers. All these diseases that you see here, visceral lymphatic disease, GI infections, organ transplants, burns, they all have in common that they have lymphatic dysfunction, inflammation, and altered immunity. We're going to talk about that a little bit soon, but let's go back. Types of lymphedema, keep in mind you have primary lymphedema, that's congenital, lymphedema precox, lymphedema tarda, secondary lymphedemas from cancer and node resection, surgical damage and infection, traumatic. I'm going to get back. Man, I got to fix. I don't know. It's got an automatic on it. Traumatic burn injuries, filariasis. All those are secondary lymphodemas. Next, keep in mind that lymphatic failure, sort of in the area of a wound, you have edema that overwhelms the lymphatics. When this persists for a long time, you'll get a tissue that is very prone to the infection because of all the localized inflammation and changes in the tissue. This is referred to by Carlson as a locus minoris resistentiae, or path or place of least resistance. And it's the fact that you've developed this inflammatory state that has produced localized inflammation, accumulation of proteins and inflammatory substances, which makes it very difficult the wound to heal, producing breaks in the skin or problems with skin healing called lymphostatic dermopathy, which is a failure of the skin as an immune organ or its ability to resist infection, to resist foreign body implantation, etc. And any wound has some level of this lymphatic dermopathy or lymphatic disruption. We don't use these people enough. We don't send patients to lymphedema therapists enough. It's often because it's not available. It's called a complete decongestive therapy. You want to make sure it's being done by a certified lymphedema therapist. There are several different types, LANA, CLTs, and it takes a long time to get certified. So, and they're in big demand, and it's often hard for patients to get in. But if you have a patient with a wound on a leg like this that you see in the upper right, getting that edema down is going to be key to your wound healing. Even a plantar foot wound, the fluid will just run out of that hole as long as it can. If you're going to use an enzymatic compression device for lymphedema, many therapists don't like them. There's some evidence recently that they are helpful, can be helpful, but you want to use one that's specific for lymphedema, like the one shown here, is not one of the ones that have been used traditionally for venous insufficiency over the years. This is a multi-chamber, but it's really kind of set up for venous insufficiency. But this one has a waveform that can be used for lymphedema. There are also arterial pumps out there if you have ischemia. They're a little harder to get certified and a little lower track record on effectiveness. E is for erythema exudate, and not we don't put edema in here because it's in the circulatory section, but it's really why you choose a wound dressing. Why do you pick a dressing? It's really to manage the fluid. Low fluid wound, high fluid wound. Do they need slight or moderate fluid absorption? Do they need a lot? The ideal dressing manages fluid, keeps humidity on the wound, allows for oxygen transfer across the wound, does not produce an anaerobic situation, provides thermal insulation, protection against infection, and it comes off easy without trauma, and it doesn't leave toxic components behind. You have everything from alginates. I don't have films on here because these are just your fluid management ones, but films don't really remove any fluid; they hold it in. And hydrogels would be up above this, and then the fluid absorbing dressings are alginates and hydrofibers, and hydroconductors, active fluid management dressings, super absorbents, baby diapers, and then some sort of negative pressure. If you expand those categories out, everything becomes a dressing, enzymatics, surfactants, antibiotic agents, collagens, nanoparticles, which are fairly new, all the antimicrobials, growth factors, and good old gauze at the bottom, which most people end up using all the time because they just don't get their hands on the dressings that they need. Our job is to make the case for good dressings, try to get your home care agencies to use good dressings and explain to them why and that it's really cost effective to use dressings that get the job done quicker. Aging. This is a peri-wound skin. It encompasses the edge, the skin around it, and there's a little saying that says, "From the peri-wound doth the healing tissues arise," and that's true. The peri-wound is the key to the wound, often edges migrating, and then offloading is in this category too. So Aging, which most of our patients with wounds are in the upper age group, unless they're traumatic wounds or they happen to be like type 1 diabetics that have developed neuropathy at an earlier age. But our older patients have thin skin, low epidermal turnover, compromised barrier function, delayed chemical clearance, and significantly decreased immune function, so they don't respond well to the challenges of a wound. Glycosylation in diabetics, you get loss of elasticity in the skin and thinning of the plantar fat pad. So your friction or trauma to the wound, shearing forces increase. The pad is stiffer, so shearing forces create more damage. The connective tissue flexibility is gone, such as the equinus, the ability to dorsiflex, but also the ability to dorsiflex and flex the toes, move the toes, wiggle the toes. They become a little more like little stiff little units. And if they have some lymphedema, then they become those little sausages down on the end of your foot. And they're very prone to interdigital pressure and shoe pressure. They lose protective sensation because of glycosylation, and glycosylation of the immune system diminishes the healing response significantly. Moisture-associated skin damage, fluid. This is not primarily for us, but if you have a patient who has a lot of incontinence, or they just don't get to change their dressings or their shoes very often, you will see moisture-associated skin damage. It's not a type of wound. It's a condition, but it may lead to a dermatitis that coalesces into a larger open area, which eventually can become a wound and should be dealt with early. So you want to make sure you take care of urine, stool, any of these things that are complicating this. Make sure they're using a dressing that doesn't trap fluid in the dressing. If you're using a total contact cast, that you have a dressing that absorbs and removes the fluid from the foot surface, and it's not becoming a little hothouse with all that fluid in there. Pressure offloading, it's everything from boots, profos for heel ulcers, seat cushions if you're dealing with patients that have sacral ulcers or hip ulcers, mattresses if the patients are bed bound, or if your patients are in the hospital for an extended period of time with an amputation. Look for all these things. If you're looking at diabetics, and this is a good guideline really for anybody with an at-risk foot, we should use guidelines a lot more than we do. They should be sort of what drives our evidence-based care. I've always kind of stuck by the 2019 International Working Group, or the International Working Group of Diabetic Foot. The newer one is 2019. There should be a new one coming out soon. It's every 2 to 4 years. This one is a pretty good one, so it may last a while. But they revise it every year with regards to diabetes. And this is the progression of offloading that they recommend for somebody with diabetes and a neuropathic plantar foot ulcer. But just remember, if they have a neuropathic ulcer for any reason, they would kind of follow this. If you have an arthritic foot with significantly compromised circulation or connective tissue disease with an ulcer, this is also a very good guideline to use. So you start with a non-removable knee-high device. And the one that the two they recommend are total contact cast or non-removables. And after looking at all the studies out there, they came to the conclusion that there's really no significant difference between these two, as long as you make the walker non-removable. If you can't do that, and the patient won't tolerate a non-removable, or you're doing dressings or something that requires, daily changes, you would use a removable knee-high. We'll talk about some of the things that happen if you can allow them to remove it. You then go to a removable ankle high if they don't like the knee-high device because it's either too cumbersome, too heavy, they just reject it. Always consider felted foam in combination with any of these dressings, or therapeutic footwear as your next choice. Now, if you go to a shoe-based system, they do not recommend using conventional or standard shoes. Not even standard therapeutic footwear. Some of these are like surgical shoes and other things like that. There's just no offloading in those. So you want to use something that you have a contoured insole, total contact cast. And remember that as soon as you go by the non-removable to the removables, they tend to only wear it about 28% of the time. If they can take it off, They take it off when they go to the bathroom. They take it off when they get a snack. They take it off when they're home. They don't wear it at home. They wear a slipper. They take it off when they're driving. I've just got to run into the store for a second. I'm not going to wear it. And in the study that Armstrong did, most of the time it was off, not on. So why is it hard to not do the total contact cast? What's the big deal? How many people actually use the total contact cast? It's used 6% as it's only used 6% of clinicians in a look at the National Registry only use the gold standard TCC for offloading on a regular basis. Only 6% of the wounds were treated that way. Why don't we use it? Patients don't like it. A lot of patients will reject it initially. That's your job to talk them into it. Time needed to apply it. I don't have time in the clinic to put these on. It only takes 10 minutes once you're good at it, and your assistant can learn how to do much of it. Cost of materials. They have kits out there now that help you with that. Reimbursement issues. I don't know how to do it. There's no excuse. Go learn. It's easy. Come to one of our workshops. The last workshop I had on total contact casting at the APMA, we had enough stuff for 40 people to do it. Everybody in the room could have put one on. 5 people hung around. The rest of them thought, I got the information. I'll go for a walk now. So they weren't actually putting on the TCC, which is why a lot of people don't know how to do it. Customizing parts, staffing, clinician coverage. Sometimes you don't have a clinician around that knows how to do it. There are contraindications. Over here, acute infection, fever, lymph nodes, sinus tracts, and perfuse drainage are all in the infection range. If you think a patient has any kind of infection, hold off on TCC till you're sure they don't. They have an active open dermatitis, that's going to drain in there, and you might get an infection from that. Edema, people with febrile lymphedema, their legs are going up and down, up and down. Cast claustrophobia, known noncompliance, arterial insufficiency, and Wagner's that are either infected or gangrene. So the offloading device used by most practitioners is the shoe, and we'll see where only 41% of clinicians use the shoe for their offloading most of the time. It has the worst data, and that doing the same thing all the time and not getting good results is insanity. So why do we use what do we use? Why do we use the shoes? We use them most of the time. Or what do we use? It's 15% of the centers use cast walkers, and most of the time people are using a shoe-based system. Patient adherence factors, they got to know what kind of disease they have, know what foot care and that they need and understand it. They have to be a person who has shown compliance. If they haven't been, they won't be. Benefits and perceptions, they need to think your intervention is going to work. Family support and practitioner reinforcement, and a lot of prayer. We developed this system for kind of working through this, which is called transitional offloading. You start with the non-removable devices. You move to removable when the wound is shallow or almost closed, or the patient is a very compliant patient. Then you can go to the shoe-based systems and the depth shoes. A lot of the other systems, we'll talk about in a second, I'm not happy with. There's lots of devices out for heels. If you look at them, they're not made for ambulation. They're for protecting the foot when patients are in bed. The social stuff has to do with making sure that the patient has adequate family, psychological, and social support to get everything done. Patients with chronic wounds suffer from a lot of problems. They have pain and immobility. They don't sleep well. They have a lack of energy because they're just sapped trying to take care of this wound and also trying to get around with all the limitations we place on them. They can't get to work. They can't do what they want, and they get depressed. Most of the patients have significant areas of depression. Areas of major concern. What's the patient's immediate social situation? What kind of environment what's the larger societal situation that they're in? I mean, a lot of our patients are in Kensington with no resources, which is a pretty tough neighborhood in Philadelphia. And then what do they believe? Do they have a good internal support system? Do they actually think they're going to get better and have a positive outlook? That's my job, to make sure they're positive about their situation. And you can't overcome everything, but you can be a real major cheerleader for your patients. So that's ABCESS. I'm going to get rid of this and get out of sharing and go back to the main deal.
Okay.
Save it so I don't lose it. There we go. So that's ABCESS. I think it will help you think through. Make sure you kind of look at all of those phases when you're looking at a wound care patient and address each one of them.
Mm-hmm. Absolutely. Well done, Dr. McGuire.
It's a lot of stuff, but it kind of fit in there.
I also, look, they'll be able to come back. They can watch or rewatch the session.
Sure.
We can share the PowerPoints. We have access to them. So,
and there's, that's, if you look in Wounds, that's the article in Wounds. It was last year.
Exactly.
Supplement that came out. You can, pick it up and take a look at it.
Exactly.
It explains it a lot more detail than I did.
Awesome. Well, we're going to get over to Jonathan Moore's presentation.
Yep. Go for it.
Jim, always great to see you, man. I'll see you again soon.
You got it. Take care.
All right. See you all in the next room. We're moving.